My name's Sam Klempner. I'm a GI medical oncologist at Massachusetts General Hospital in Boston, Mass. So, as we all know, one of the major roles of the oncologist and the multidisciplinary team is defining stage, both clinically and pathologically. This is how we decide and inform prognosis for our patients, but also how we define and develop individualized treatment plans. Certainly within the staging modalities, CT and PET-CT have added significant ability to detect distant metastases as well as added information for regional staging. But T and N stage is still well covered by upper endoscopic ultrasound. So it's primarily used to assess T stage and N stage in our practice, primarily at the time of new diagnosis, but can also be incorporated in response assessment, particularly in patients who are not proceeding to surgery. It should be noted that clinical staging and pathologic staging are both relevant, although the survival outcomes are certainly better correlated with pathologic stage than with clinical stage. And EUS really here provides a complement to imaging modalities such as PET-CT and contrast-enhanced CT scan. Now, we know from several studies that the sensitivity and the specificity of EUS are greatest in higher stage tumors, particularly T3 and T4 tumors. As well as assessing some adjacent structures in esophageal cancer. This is particularly relevant in assessing involvement of the posterior airway or potentially some of the great vessels such as the aorta. And this greatly helps our surgeons decide on technical resectability as we embark on treatment plans in newly diagnosed non-metastatic patients. The sensitivity of EUS is roughly 85% or so for assessing nodal involvement in esophageal cancer. So coupling EUS, particularly with the ability to do FNA, if you don't have to go through the tumor, does further improve accuracy of nodal assessment. And this can be helpful in situations where there is an equivocal node by imaging, for example. Like many tests, EUS is operator dependent. And the accuracy, if you move farther down the upper GI tract into the stomach, the range of accuracy becomes even broader depending on the series that you look at. For example, some large studies correlating endoscopic staging to pathologic staging in patients with gastric cancer who are going right to upfront surgery suggest that the overall accuracy is only 46% for the T stage and 67% for N stage compared to pathological staging. One important role for EUS that perhaps us as medical oncologists don't see quite as much is identifying patients with suspected early disease who may be candidates for endoscopic therapies, such as ESD and EMR. In experienced hands, these procedures can be both diagnostic for distinguishing, say, pathologic T1A versus T1B, but also therapeutic. And in true early stage cancers, there is curative potential for EMR and ESD. And there's a substantial literature in gastric cancer led primarily by our Asian colleagues where they see earlier stage disease as a result of screening procedures. In patients with larger or bulkier tumors, there may be a lesser role, or clear distant disease, there may be a slightly lesser role for endoscopic ultrasound in that it may not ultimately change our management. In a patient with a bulky nodal disease or clear metastatic disease, one has to ask themselves, what are they going to do with the information obtained from an EUS, and will it change the management of the patient? There are, of course, some technical limitations and issues with EUS. The ultrasound probe is larger than the standard endoscopy camera. And so patients with obstructing or nearly obstructing tumors are often unable to get adequate EUS since the probe cannot pass the tumor. Similarly, patients with very high esophageal cancers or cervical esophageal cancers often have difficulty with EUS owing to technical limitations. So EUS overall is a particularly helpful tool for T and N staging, primarily in patients who there's consideration for early disease or equivocal nodes on imaging. In patients where there is clear bulky regional nodes or distant metastatic disease, the role for EUS may be somewhat limited, although this should certainly be individualized among all of our patients.